good afternoon. So I would like first to thank Ahmed for the invitation. It's a pleasure to be here. So I will be talking about combining pharmacological intervention with TMS. So this is my disclosure. This project has been supported by an in-kind donation of a coil from Brainsway and also a grant award from Pfizer. So mostly the context will be around the role of insula in nicotine addiction. So mostly this started some time ago now, in 2007, by this paper from the group of Antoine Béchara. Mike V was the first author, showing that people that had a stroke of the insula were able to quit smoking and not relapse to smoking behavior. So that was, at the time, very interesting because the insula was not really part of the main interest in the neurobiology at the time. So following this paper, I decided to bring this into the lab to start to selectively test the role of the insula because, the stroke do not destroy selectively the insula, so there are nearby also regions that get affected by the stroke. So I felt it's important to test directly the role of insula. So I used this nicotine self-administration paradigm, and we trained rats to self-administer nicotine, and then they were tested for nicotine taking under different schedule of reinforcement, fixed ratio and progressive ratio schedule of reinforcement. But also we tested them into reinstatement paradigms, so where some behavior is extinguished and then reinstated by presentation of cues or nicotine priming. And so the first study we have done was to inhibit the insular cortex in those rats bilaterally with infusion of GABA agonist. And we have shown that there was a strong reduction of nicotine taking and nicotine seeking. And so this has been shown by us for both granular and agranular areas, so it's probably a large effect of different parts of the insula there. But, infusion of GABA is probably not very physiologic, so then we decided to test the impact of DBS, so deep brain stimulation, implementing the rats with electrodes directly into the insula bilaterally and try to replicate those effects. And we were able to show that DBS of the insula also reduced nicotine taking and nicotine seeking, but less effective than the infusion of the GABA agonist. So, and then you are all aware of the work done in clinical trials that have led to the approval of the Brainsway coil for smoking cessation, and this Brainsway coil target insula, but also the prefrontal cortex. So it's not completely selective of the insular cortex. But one of the gaps that remain, I believe, in this area for treatment therapy for smoker is how those TMS stimulation coil can be used in combination with pharmacotherapy. So it's quite likely that pharmacotherapy will engage the brain differently than TMS, so there may be value of combining those two treatment modalities. So we decided to test this idea by combining varenicline with insular TMS. So those results have been published now in Brain Stimulation Journal. I would like to make it clear that the coil we have used here is H11 coil, which is an insular selective coil, so it's not exactly the same as the coils that got approval for smoking cessation, and for us the idea was to try to engage insula more selectively. So what we have done here is a randomized double-blind sham-controlled trial. So our goal was to get 50 participants with tobacco use disorder, willing to quit, and then they will be randomized to either sham RTMS or active RTMS. And all participants in the trial received open label varenicline for 12 weeks, which is the standard duration. And for the TMS session, we gave 20 sessions directed to the bilateral insula. So it was 5 days a week for 4 consecutive weeks. And then there was like weekly visit for the first month until 12 weeks, and then 6 months follow-up visit. So we didn't use the Q induction paradigm here as the mentioned. It's an approved way of using the approved coil from BrainsWave for smoking cessation, but here we only used the TMS session with no Q. So this is a graph illustrating the study design, and mostly we had a target quit date that started a bit after initiation of varenicline, and then our main outcome was at week 12, the 7-day point prevalence abstinence, but we also measured the outcome at the end of trial. Okay, so that's the enrollment, the consort diagram. So we have contacted around 600 participants, and then only around 60 were assessed for eligibility. We have enrolled 50. Then they were allocated to active TMS or sham. So we got around 24 to 18 participants, and analyzed in the final analysis were all the patients. It was an intent to treat analysis. So this is the demographic of those participants. So mostly mean age was around 46, 43 years old. Fagerstrom test for nicotine dependence 6.3 or around 5.6. And they had a high level of cigarettes used per day, around 19 in the sham group and 17 in the active group. So we enrolled a little bit more male compared female. Okay, so that's the main result on our primary outcome. So this is abstinence rate at 12 weeks. And you can see here that abstinence rate was much higher, around 80% in the active group compared to the sham group. So this was statistically significant. So we were quite pleased to see that, but when we look at the result of the trial over time, so here are the results of the 7-day point prevalence at week 4, week 12, and end of trial, week 26. So you can see that we didn't observe any difference at week 4, which was here the end of the TMS treatment. And so we got a significant difference at week 12, but this effect is no more statistically significant at end of trial. So something has happened between week 4 and week 12, while the participants were not getting TMS at that point. But so we speculate that maybe the TMS they got before had some impact on the brain that took a bit of time to materialize. But it seems this effect was not prolonged at the later time point. And those are the results plotted for craving and cigarette consumption over time. So there was no strong effect observed there. So in conclusion, as you know, like we have currently a deep TMS that is an effective approved treatment, but we have still big gaps in terms of how to use this treatment modality in real life. And I think in the area of combination therapy could be an interesting area to explore further in order to improve efficacy further. So we have lots of factors that may be involved in treatment response, the timing, the duration, frequency. But based on our result, it seems that maybe a few weeks of RTMS are enough to produce an effect, but this effect may wean off. So there may be a need to give booster session to maintain the effect over time. I wanted to mention here this article that Victor mentioned on how to translate the insular TMS finding into real world. I think that's a big challenge currently, and for those of you that are interested to know more about this. And I would like to thank all my collaborators in Toronto that were involved in the work, as well as Dr. Zengan, for sure, that has been an early collaborator with us on this work. And thank you for your attention.